to deal with that. During this webinar, I will focus more on the vertebral artery anatomy and also the approaches to reach the vertebral artery. Can you just open your video that I can see someone in front of me? So I'm sure that it is working because I have absolutely no feedback. So I see Vittorio Civelli and Imad Ula. As Vittorio will be the next one to speak about the angiographic aspect related to the vertebral artery. I will give you the floor in 20 minutes. So I will start by sharing my screen. Just a few seconds. I hope you will be able to see my screen. So as I told you, I'm Michael Bruneau, working in Brussels. I have some experience on the vertebral artery, and I will focus my talk now on the vertebral artery anatomy and the related surgical approaches. So as most of you know, the vertebral artery is subdivided into 4 segments. The first segment is the V1 segment, called also ostial segment, running from the subclavian artery up to the transverse foramen at the level of C6. Then the vertebral artery has an ascendant trajectory, which is called a V2 or transverse artery segment, because the vertebral artery comes and move into each transverse foramen from C6 to C2. At the level of C2, the vertebral artery make a lateral loop, then a upper loop, and then turn to enter the dura mater at the level of the foramen magnum. This segment is called the V3 segment or suboccipital segment, and then intradurally you have the V4 segment. I put the V1 and V4 segments in red and the 2 other ones in blue because, in fact, it's important to understand that the V2 and V3 segment are in fact surrounded by a periosteal sheath, and surrounding the artery within the sheath you have an important venous plexus. It's why I put that in blue. This is a big anatomical difference and it has many surgical consequences compared to V1 and V3, which are truly the artery that is visible directly when you expose the artery. This is just the junction between V1 and V2, and you see here the periosteal sheath surrounding V2, and here at the level of V1, followed by the vertebral vein. This is a big difference when you are dealing with the vertebral artery. So on an anatomical point of view, there are a few branches arising from the vertebral artery. The most important one is the anterior spinal artery. Importantly, this anterior spinal artery never comes below the level of C3. Above the level of C3. It's always below. Above C3, you have an anterior meningeal artery, which is also important when you operated on foramen magnum meningiomas because it's one of the arteries feeding such a tumor. You have also muscular branches arising from the vertebral artery, V2 and V3 segment, and through those muscular branches, you have sometimes important anastomosis that developed in case of occlusion of the vertebral artery. What is important when you are dealing with the vertebral artery, exposing the vertebral artery surgically, is to know which type of vertebral artery you are exposing. And it's important to know the size of the vertebral artery. You are exposing the vertebral artery on the dominant side or the hypoplasic side. In fact, you can have most of the time equal vertebral artery, but in quite a significant number of patients, you will face a small vertebral artery. And if you face a small vertebral artery, in fact, there are 2 conditions. The vertebral artery can be called hypoplasic if the vertebral artery is fusing with the contralateral one to form the basilar trunk. In case of any damage to the vertebral artery, normally there is no consequences of that. It's not the case when you are exposing a small vertebral artery, just like this, but which is ending into a pica. This situation is completely different. It is called an atretic vertebral artery. And then in case of atretic vertebral artery, if in case of problem with the management of the artery, in case of injury, of sacrifice during the surgery, you expose the patient to devastating consequence with stroke in the posterior fossa because it's the territory of the pica. So it's a terminal supply. What are the other important anatomical variation that you have to know when you are exposing the vertebral artery? Loops can be present, and you have also an abnormal level of entrance, meaning that the artery is not entering into C6 but above. And we made a very large study about that, about the trajectory of 500 vertebral arteries. Normally, as you know, the vertebral artery enters the C6 transverse foramen. It is the case in 93% of the patient. But the vertebral artery can enter above into C5 in 5% of the patient, into C4 in 1% of the patients, and even more cranially in C3. Anecdotically, the vertebral artery can also enter into the C7 transverse foramen, but it has less consequences on a surgical point of view. You can detect that easily. I illustrate here sagittal MRI, and you can see the trajectory of the vertebral artery and where it enters the transverse foramen. It is visible also on axial slide, basically on MRI without any contrast. And you see here the vertebral artery in front of the transverse process, while on the other side, the vertebral artery is inside the transverse foramen. Clearly, it can be detected on angio-CT, again, inside the foramen, but in front of the foramen, meaning that the vertebral artery is not entering into C6, but above. You don't know the level, but you know that it is above. It is also detectable even on a basic CT scan, bone sequences. You see here a wide transverse foramen. You expect the vertebral artery will be inside. Here you see a very small one. The vertebral artery will not be inside. Is it important to know that? For sure, because when you expose the vertebral artery through a lateral approach, you will try to reach the transverse process and the bone in front of the transverse process because it's where the vertebral artery is exposed. Because normally the vertebral artery, when inside the foramen, the vertebral artery is protected by the bone. So if you cut the longus colli muscle and you are not aware of this variation, that the vertebral artery is not inside the foramen but outside, then you have the risk to injure the vertebral artery. So be very careful with such anatomical variation into the level of entrance because you can start your surgery with a devastating complication. As I said, there are also medial loops that are important to detect preoperatively. This is a corporeal loop detected in 1.2% of the cases. It's not so anecdotal. And if you perform a basic cervical corpectomy without being aware of this, if you use a drill, you have a risk to injure the vertebral artery. This is a medial loop into the corpus. You have also medial loop into the foramen. That is clearly visible. And in this case, if you treat a disc herniation at this level, not being aware of this loop, you can expose the patient to a complication. It can be detected on basic exams and, of course, on angio-MR with reconstructions. You have also lateral loops. Those are of different types and mainly related to osteophytes, which are pushing the vertebral artery laterally. And in this situation, when the encarthrosis grows into the foramen, it can even result in a spontaneous obstruction and occlusion of the vertebral artery. Those are the lateral loops that can be detected. When you are exposing a vertebral artery at the craniocervical junction level, what is important to know, because it's quite common, between 5 and 20% of the patient, you can face a pica variation with a pica not arising from the intradural segment of the vertebral artery, but arising extradurally from the horizontal portion of the V3 segment or even the vertical portion of the V3 segment. So the course of the vertebra, the pica is completely different. And here by sample, you have a course between C1 and C2, which can be truly problematic if you are not aware about that. You have a very rare anatomical variation related to the vertebral artery, meaning variation with the vertebral artery not arising from the subclavian artery, but from, by sample, the carotid artery. You have also fenestration of the vertebral artery here at the level of C2, with in fact the vertebral artery which has two trunks, inside the periosteal sheath, it is called a fenestration. But if you have a duplication of the vertebral artery, you have truly two vertebral artery, one in correct position and the other one who has a different course outside the periosteal sheath. In this situation, coming and having a trajectory between C1 and C2. You have also very rare anatomic anastomosis between the carotid system and the vertebro-basilar one. You see all the connections that can be observed, the trigeminal artery, otic artery, hypoglossal artery, and proatlantar artery. Those anastomoses are very rare and sometimes associated with aneurysm, and they have to be detected preparatively because they can be source of complication if you are not aware of that. An important aspect that has also to be discussed when you expose a vertebral artery at the cervical level or craniocervical junction level is when to perform a balloon occlusion test. In some conditions, it has to be performed. If the vertebral artery is minor, less developed, as I said before, you have just to extrude termination into a pica to avoid a Wallenberg syndrome in case of sacrifice. If the vertebral artery that you have to expose is equivalent or dominant to the contralateral one, you have to evaluate the risk of vertebral artery injury. The risk can be low or high. The high risk exposure are related to the severe compression of the vertebral artery, the encasement of the vertebral artery in case of malignant tumor, if the patient has already been irradiated or operated on. When one of these criterions is present, the risk is higher to have a vertebral artery lesion during the exposure, and then it is better to perform a balloon occlusion test. If the balloon occlusion test is well tolerated, of course, you preserve the vertebral artery. If it is less or not tolerated, then you have to be prepared to perform a bypass if needed in case of any difficulty with the exposure. So what are the approaches to the vertebral artery? At the cervical level, it is called the lateral approach, and it is a little different from the classical anterior approach that is used to perform any disc herniation or anterior access to the cervical spine. In which way it is different? In the anterior approach, the dissection is performed medially to the cervical vessel, meaning the internal jugular vein and the common carotid or internal carotid artery. In the lateral approach, the superficial layers are the same. The incision is at the level of the medial border of the sternocleidomastoid muscle, which is put laterally. And then the dissection is performed laterally to the vessel with the goal to reach the bone in front of the vertebral artery at the level of the transverse process. In front of the transverse process, you have the longus colli muscle, and above the longus colli muscle, you have the sympathetic chain. So this is the approach at the different level of exposure of the vertebral artery, V1, V2, and V3. At the level of V1, the incision is performed along the medial border of the sternocleidomastoid muscle. You can perform a contra-incision over the clavicle. As I said, lateral dissection along the lateral border of the internal jugular vein with a coagulation section technique, meaning that first you take the tissue, then you coagulate on it, and then you divide it, and then you work in a perfect, clean surgical field. At the level of C6, you may have to divide the omohyoid muscle to enlarge the access to this level. The approach I will detail later on for the craniocervical junction is in fact the same dissection along the medial border of the craniosternomastoid muscle, but then turn around the mastoid, and you will have through this access an approach to the level of C0, C1, C2. So what are the tips and tricks? As I have said, if you would like to work confidently, you have to reach and target the transverse process where the vertebral artery is protected by bone. Then you have to perform a superosteal dissection. This is the first key point. The transverse process is a bone protection, and then you have to palpate it when you have performed your approach to know where the vertebral artery is protected. Then you divide the longus colli muscle above the two consecutive transverse process, and doing that, you know that you were perfectly confidently, and you will be able to expose the deep field just in front of the vertebral artery. Of course, we have dissected previously the sympathetic chain, and you can protect the sympathetic chain with the aponeurosis of the longus colli muscle that is turned around and that is maintained in place with some sutures. So the superficial dissection, what is this concept? The most important concept when you expose the vertebral artery. As I told you before, V2 and V3 are surrounded by a periosteal sheath and by a venous plexus. What does it mean on a surgical point of view? If you directly go with your Kerrison here to open the anterior branch of the transverse transverse foramen, you will directly injure the periosteal sheath, then the venous plexus, then you will face troublesome venous bleeding. And that is very uncomfortable. If you would like to work in a perfectly clean surgical field, in fact, you have to divide the periosteal layer in front of the transverse process. And then with a spatula, you elevate the periosteal layer outside and then inside the transverse foramen, making that the periosteal layer stay in place along the periosteal sheath of the vertebral artery. So it's in continuity. And then when you use your Kerrison at this level, you are perfectly safe and you will not disrupt this fine layer and you will not have any venous bleeding at all. This is the opening. And if you would like to mobilize and transpose the vertebral artery, then you have to put your spatula inside the transverse foramen and again elevate the periosteal layer, and then you will be perfectly clean for your surgical exposure of the vertebral artery. Just take care that the level of C6, the lower level where the periosteal sheath reach the transverse foramen, you have a ring, and this ring is sometimes a level of more adherence. So if you have a bleeding problem, you can control the venous bleeding with direct coagulation on the sheath itself, or you can even pack with Surgicel and then, or use Flossil, and then you will be perfectly able to control any bleeding around the vertebral artery, meaning venous bleedings. So what type of tumor you can treat with the lateral approach to the vertebral artery? Many tumors, parapharyngeal tumors, soft tissue tumors, bone tumors. There are a wide variety of bone tumors, primary one, but also metastasis, secondary one. You have also extramedullary tumors. Those are the type of extramedullary tumor extremely interesting to treat with a lateral approach, meaning not the one which are intradural, purely intradural, but the one which are by sample dumbbell shaped. And the interest of using a lateral approach compared to a posterior approach is that you can remove all the components of the tumors. You have not to perform a facetectomy. You will be confident with the vertebral artery which is exposed, and you will devascularize the tumor at the first steps of the surgery. So there are a lot of interest to make those surgeries through a lateral approach. And this is a case to illustrate that. The patient was sent to me after having been operated on by a posterior approach. What does it mean? The surgeon performed a facetectomy. The patient complained of cervical pain. The foramen is enlarged, and finally, the residue is growing because the tumor is not completely removed. And when you see the lateral approach, you see the exposure you have. This is the vertebral artery at the level of C3. This is the loop at the level of C2. The foramen is enlarged by the tumor, and by this lateral approach, you have an access to all the structure after a superficial dissection of the vertebral artery. This is the exposure of the vertebral artery. This is the final exposure. This is the tumor. And then you have just to resect the tumor by an intratumoral debulking, then a peripheral dissection, and you see the situation at the end of the procedure. This is the lateral artery completely decompressed now after complete resection. Of course, bone tumors can be treated by this lateral approach. This is a chordoma. You see how it is destructive at the level of C2, C3. I just showed that to illustrate that at this level you have to spare the 11th cranial nerve, and then you have to be a little imaginative if you want to perform a reconstruction if needed. This is a distractable cage put obliquely with a unilateral fixation. This is a plate with two screws, one above and one below. So the lateral approach is also very interesting if you would like to decompress selectively a nerve root compressed by oncodiscarthrosis. In this situation, we published that with Bernard Georges. We can selectively remove the compressive element without any need for fixation. So now, what are the approaches to the vertebral artery at the level of the craniocervical junction? I speak until now to the exposure at the cervical level. Now, at the craniocervical junction level, there are basically two approaches, the antero-lateral approach and the posterolateral approach. The posterolateral one, you are very familiar to this approach. This is a basic midline approach with some contra-incision towards the pathological site. It is used by sample to treat foramen magnum meningiomas, and I refer here to the classification developed by the Professor Bernard Georges. You have also the anterolateral approach, as I say, which is the upper extension of this lateral approach, dedicated to treat lesions, but which are not intradural as for the posterolateral approach, but extradural lesions at the level of the occipital condyle, at the level of C1, C2. It's also a way to reach the jugular foramen. Technically, you have to leave just a cuff of 5 millimeters of muscle when you divide the sternocleidomastoid muscle to reapproximate it at the end of the surgery. Again, the exposure is performed laterally to the internal jugular vein. You have to spare the 11th cranial nerve and to reach the transverse foramen at the level of C1. Importantly, you have to understand, and it is quite unique, that the anatomical relation of the vertebral artery are changing at the level of the craniocervical junction depending on the position of the head. Because C1 is moving laterally and anteriorly, if here in this situation, the head is moved towards the right side, the left transverse foramen will move anteriorly. And then in neutral position, both segments above and below the C1 transverse foramen are perpendicular, but when the head is turned, both segments become more and more parallel. This is truly important because all anatomical relations are changing at this level depending on the head position. And depending on the region that you have to reach, you have to turn more or less the head. This is the exposure I have just detailed. When you reach the C1 transverse foramen, you have to divide the muscle inserting into it, superior and inferior oblique muscle, and then again perform this superosteal dissection to elevate this periosteal layer, then open the foramen with your Kerrison, and then you are able to mobilize the vertebral artery to transpose the vertebral artery if you have to reach anterior structures. And just a case to illustrate, in fact, both approaches. This is a child with an aneurysmal bone cyst, and you see the evolution within 6 weeks. Very evolutive, fast-growing tumor. The patient received first a percutaneous embolization to decrease the blood vascularization. It's a very young children, 6-year-old, so it's not so many blood reserve. The first surgery consisted in a lateral approach, and by this lateral approach, you see the exposure of the vertebral artery at the end. The main component of the tumor was removed. Even a graft, iliac graft, was put inside a destroyed C2, and you will see that after a few months, this graft is completely inserted. Then the patient is turned in the prone position. The posterolateral approach is performed to remove the posterior aspect of the tumor and then to perform a fixation in order to restore the stability at this level. And I put here a graft, also a bone graft between C1 and C3 in order to make the fixation stronger. So those are the aspects I would like to develop with you. I cannot end this talk without speaking about my former trainer, who was Professor Bernard Georges. I learned everything about the vertebral artery thanks to him. So I would like to finish this talk with a short memory to him. Thank you for your attention. So I will stop to share my screen. And I see that also Paolo Di Rosso joined us. He will be the third speaker. I will have to leave a little earlier. I will not be able to stay until the end. So it's my pleasure now to introduce the next speaker, and I propose that Paolo introduce then the other speakers afterwards, who is Vittorio Civelli, who will speak about the angiographic aspect. Start with Vittorio.
Everybody, there's a
we can hear you, Vittorio, but people who have not muted themselves.
Yeah.
Paolo, maybe mute
Yeah, I can hear you. Hi, everybody. I can hear you, Vittorio.
Okay, thank you. Paolo, can you? Okay, now it's okay. I share the screen. So, okay, can you see the screen?
Yes.
Exactly. So, okay, thank you very much. It's an honor to me to be here. It's not easy to to talk after Professor Bruneau is a great expert of vertebral artery, and but I will do my best. So I will give a more the radiological point of view concerning the anatomy of the vertebral artery. So I have no disclosure for this talk. So as we saw before, vertebral artery is the first and main collateral branch of the subclavian artery, and normally enters the transverse canal at the C6 transverse foramen. And then it contours the atlas and gives its largest tributary, that's the posterior inferior cerebellar artery, the pica artery, after piercing the occipital membrane. And then it joins the other vertebral at the vertebrovascular junction and to form the basilar artery. Going in a little bit deeper into the segmentation, there has been historically several proposals of segmentation of the vertebral artery, and we can identify this segmentation as the most used today. We identify four segments of the vertebral artery, the so-called V1 or preforaminal segment. And its origin, it got from the origin to the transverse foramen of and then C6. Then we have the V2 or foraminal segment that goes from the transverse foramen of C6 to the transverse foramen of C2. Then we have the V3 segment that goes from the C2, and then it loops and to the and continues to the C1 and pierce the dura at this level. And then we have the V4 or intracranial or intradural segment that goes after piercing the dura and to the confluence on the medulla to form the basilar artery. But to understand a little bit more the anatomy of vertebral artery, we can go a little bit deeper into the embryology. It will help us to understand the variation that we see when we perform TT studies or angiography studies. So in the early fetal life, we have some segmental horizontal branches that extend from the cervical to the sacral region, and they vascularize the developing somites. And then all the transverse arteries are connected by pair longitudinal channels that we can identify as the ventral aorta and the dorsal aorta. And then more longitudinal channel will follow in the developing fetus. So the dorsal and the ventral aorta are connected by seven pairs of aortic arches, and the seven segmental artery from the lower end of the vertebral artery. And then we'll send a branch to the forelimb bud and to form the subclavian artery. On the left side, the seven dorsal intersegmental artery persists, and they will form the entire proximal left subclavian artery. On the right, the seven dorsal intersegmental artery will form the distal third of the proximal right subclavian artery. And then the proximal and mid-zone of the proximal right subclavian artery are formed by the right fourth aortic arch and the right dorsal aortic root. So the point is that the anomalous origin arise from aberrant anastomosis at any time and during the embryonic development of the arch. and the time and location of these anastomosis will determine the ultimate adult anomalous origin. So in an embryological point of view, the segmentation is a little bit different. We can identify three segments. We have the first segment or proximal segment that correspond to a persistent primitive intersegmental artery, generally the sixth. Then we have an intermediate portion consists of a series of longitudinal anastomosis connection established between the first 5 cervical intersegmental arteries. And then we have the distal portion that's derived from the proatlantal artery and from the terminal vertebral artery. So in each level into the cervical level is vascularized by these horizontal arteries that will vascularize the vertebrae, the cervical spine, the occipital bone, and their associated nerve, muscular and vascular cutaneous elements. And these vessels are united by some longitudinal arteries. And we have the vertebral artery, but we have other vertical axes that will be formed during fetal life. So we'll have the ascending cervical, the deep cervical artery, the occipital artery, the ascending pharyngeal, and the supreme intercostal artery. And so any vertebral artery dysfunction during the congenital, that's congenital or acquired, is most likely to be taken over by this transverse segmental anastomosis of the Abramonian vessels. And so the variation become very understandable and predictable. And this is a representation scheme. So we have these segmental arteries, and then we have the development of these intersegmental vertical arteries. We have some kind of regression, and then we have the formation of the adult form of the vessel. And so we can explain some different configuration that we can find in our studies. So we can have, for example, the direct origin of the vertebral artery from the aortic arch. And it can be explained by a lack of regression of the sixth segmental arteries and the permanent connection with the aortic arch. And it can be identified on the angioscan and angio-CT study. It can be alone or associated with other more complex anomalies like this bovine trunk, or even more complex one, as in this case where we have an independent origin of the whole supraortic trunks. Or we can have duplications, a tree duplication of the origin of the vertebral artery, as in this case. And here again, it can be explained by an embryological point of view by a lack of regression of the two intersegmental pairs, and so the persistent in adult life. Or this is another case of a true duplication of the origin of the left vertebral artery. And so it's an injection from the part originating from the subclavian artery, and then a retrograde opacification of the duplication and the aortic arch below. It can have some clinical implication. There was a patient referred for a suspicion of vertebral artery dissection, but the injection of the brachiocephalic trunk showed no vertebral artery and no reconstruction of the vertebral artery was seen from the deep or the ascending cervical injection. But injecting on the left side, the left vertebral artery allowed to visualize the right one. And so the right vertebral artery was found, finally injecting the supreme intercostal artery that gave origin to the vertebral artery. Or again, the right intercostal artery can originate from the vertebral artery in an inverse manner. We can have a far lateral origin of the vertebral artery from the aortic arch. Or again, we can find this kind of anomalous origin from the right common carotid artery. And this is a configuration that's more frequent in the right aberrant subclavian aortic arch configuration. We can have some duplication, again, that can be explained embryologically, or we can have a different configuration where a so-called vertebral artery origin distal from the inferior thyroid artery. It can happen on the left side, or it can happen on the right side, where we can see the inferior thyroid and the right vertebral artery. And in this case, we can also see a different point of entry in the interforaminal canal. And maybe we can think that embryologically we are talking about a different vessel. So, for example, again, we can see a so-called vertebral artery that entering the neuroforamen at C5. But actually, from an embryological point of view, we see a deep cervical artery that reconstitutes the vertebral artery via muscular transverse anastomosis. And the fact that the vertebral artery originates distal to the inferior thyroid artery confirms that the proximal vessel is really the deep cervical artery. And it can have clinical implication. We can see a post-op CT scan after a cervical fusion, and we can see the left CC screw within the vertebral foramen. But during surgery, there was no indication of vertebral injury or any postoperative change. And when we see the angio study, we see that the so-called vertebral artery has an extra osseous course entering the foramen at C3 level. This level, very far above from the CC screw. Embryological, this so-called extraosseous vertebral artery is not the same as a true vertebral artery because it's a tip cervical artery that reconstitutes the true vertebral artery. And the true vertebral artery below the foramen is hypoplastic. So we had a regression at this level, and so the deep cervical artery take over the true vertebral artery. And this is what we see. But then we can have common origin, for example, in this case, with the common origin of the vertebral artery and the deep cervical artery. And we can see, again, the level of entry at C5. Or we can have a different level of entry at C4, for example. And in this case, usually the proximal vessel is the ascending cervical artery from an embryological point of view. And it can have clinical implication, as in this case, we have a vertebral artery entering in C4, and is highly more mobile from a normal vertebral artery. We didn't consider that when we decided to treat these dissecting arteries with a flow diverter stent. And the patient arrived two months after the treatment with some minor stroke, and we can see the CT scan after showed some metal parts inside the brain that weren't present 2 months before. And looking at the stent was completely broken. And one of the possible causes was the increased vascular motility of the vascular anomaly. And as we saw before, is possible to have an asymmetry of the two vertebral artery. And more than half of the time, the left is larger. And to understand if we have a true hypoplastic vessel, is always useful to look at the size of the foramen, because embryologically the foramen follow the vessel. So as we saw before, there are several anastomoses that can be identified between the other longitudinal vessels, and the anastomotic channel are formed by transverse segmental arteries at the different level. And the anastomic artery varies depending on the level. And this is a beautiful picture. It was an injection of a vertebral artery in an occlusion method that allowed to identify all these possible connections: the arteriospinal artery in red, the radiculomedullary artery in white, or the epidural arcade in the yellow, or the odontoid arcade in purple, the muscular branches, or the neuromeningeal trunk and the pharyngeal trunk of the ascending pharyngeal artery, and again the occipital artery, the deep cervical artery in pink, and the ascending cervical artery. This is a case of a vertebral origin dissection where the there are the ascending cervical arteries allowed to reconstitute the vertebral artery, and also took over the territory of the deep cervical territory that was hypoplastic. Another case with the injection of the ascending cervical artery that had anastomosis and reconstituted a dissected vertebral artery, and also allowed to keep the vascularization of the spinal cord. As we saw, there are anastomosis with the occipital artery, and we can have the so-called type 2 proatlantal artery, that the second intersegmental artery, and it can persist during the adult life, even if it's rare. And but usually it regresses, and but it's always present as a potential anastomosis at this level. So from a neurointerventional point of view, we don't use liquid embolic agent in the proximal part of the occipital artery because it can open this anastomosis, and then from an injection from the occipital artery, we can find ourselves with a vertebrobasilar stroke due to the opening of this anastomosis. We can have the type 2 proatlantal artery that can persist very, very rarely in the adult life, but usually regresses. It's very important to know the anastomosis with the ascending pharyngeal, especially when we are dealing with this kind of lesion. For example, for preoperative embolization, we never use liquid embolic agent in these cases, because we can see this injection in the ascending pharyngeal allow the opacification of the two vertebral arteries through the odontoid arcade. And this is another case showing the same configuration. So in these cases, we prefer to do proximal embolization to avoid to open this kind of dangerous, so-called dangerous anastomosis. Then it's important, considering the anatomy of the vertebral artery, it is important to consider the vascular supply to the spinal cord. And we know that supply the cervical anterospinal artery by multiple radiculomedullary arteries. From an embryological point of view, we know that even the arteriospinal artery is formed from a midline fusion of longitudinal anastomosis, and the radiculomedullary artery that supply at every embryological level partially regress in adult life. So these are the main apport for the vascularization of the cervical spinal cord. So it's important to look for them. Sometimes the continuity of the anterior spinal artery is assured by homolateral apport to the cord, and sometimes from bilateral apport to the spinal cord. So coming to the conclusion, the two vertebral arteries then end up and form the basilar artery. And the main collateral branch in the V4, so intradural segment, is the pica artery. And even the basilar artery is formed from a fusion of longitudinal neural system, and it can be explained from an embryological point of view as an extension of the segmental arrangement found in the spinal cord. The variation that are very common at the level of the pica can be explained by these different taking over during the fetal life, and we can find ourselves in situations like this with an extra dural origin of the pica. But if we look very carefully, we can see a perforation at the level of the normal origin of the pica. So the cortical part will be vascularized by the extradural, but the spinal cord, the perforator, will be taken over by this perforator. So it can allow us, for example, to sacrifice, if it is needed, this pica without potential spinal cord damage. We can have duplicated pica, as in this case, where we have the two origins, one origin from an extradural and one origin from the intradural segment, and the extradural will take in charge the vascularization of the cerebellar hemisphere, while the intradural component supply the medullary and vermian segments. And again, in the extreme spectrum of the embryological variation, we can have also the occipital origin of the pica from the occipital origin of the pica. From an inner point of view, we can sacrifice the pica if we have to, if we have a low origin, if we check very carefully with our 3D acquisition the absence of perforator, and if the ICA has a good caliber. So as a take-home message, I will always love to say what one of our masters said: the anatomy is the cheapest way to be safe. And I thank you for your attention.
Okay, thank you, Vittorio. It was a really nice and comprehensive overview of the anatomy of the vertebral artery, really in details. So thanks a lot. Can you guys hear me?
Yeah, we hear you well.
Okay, perfect. So I think it's my time. So I will start to share my screen with you. Okay. Can you see my screen?
Yes.
Can you see my screen? It's okay?
Yeah, we see your screen. That looks
Okay,
perfect.
I start. So I will talk about in details about the antero-lateral approach. It's a kind of approach that I learned in Paris from Sébastien Frolich. Hold on a bit. Okay, that I learned in Paris when I was there for the fellowship in 2019. Now I work in this place in Italy. I always like to put the map of of Italy to let you understand where I work. It's actually a nice place in the center south of Italy. It's a big department in between Rome and Naples with many OR. We have a lot of activity, a lot of recruitment all around, but the village is really really small one. So these are my two conflicts of interest. We don't have only a good, beautiful hospital, but we have a nice lab that we set up 3 years ago, where we could do many courses of different types, and we have also a nice fellowship program which is founded thanks to this foundation from Milan, from Andrea Gardia. These are the fellows that came to the lab so far and participated to all the dissection that you see in my presentations. So all the dissection comes from these 3 labs. So let's start with the topic. As Michael Bruneau already said, it's not possible to talk about the antero-lateral approach without mentioning Bernard George. That was the one that described this approach for the craniocervical junction, and not only also for the lower cervical spine. So many different approaches are available for the craniocervical junction. So the posterior approach, classic midline posterior approach, posterolateral approach, so-called far lateral approach, so more lateral to get lesions that are more ventral. The transcaudal approach, even more ventral with more extensive bone removal. Then we have the antero-lateral approach, so completely different kind of approach. We will see it, and we don't want to forget definitely the anterior endoscopic transoral and now the transorbital approaches. So which are the pathologies that that can affect the craniosacral junction? Most of them are meningiomas, schwannoma, and vascular lesion as intradural pathologies, and extradural lesion as chordomas, metastasis, and primary bone tumors, which are those that are mainly treated with the anterolateral approach. And so just to summarize a little bit, farlateral approach is better for intradural lesion, not all the time. It can be used also for some chordomas at the craniosacral junction. The anterolateral approach is mainly for extradural lesion from the border of foramen magnum to the lower cervical spine to the C7, midline and lateral pathology, and extended endoscopy endonasal approaches are done for the midline pathologies, extra intradural extension above C2, so from anterior. So this kind of approach give you access to very nicely to bone lesions that affect, involve the condyle, C0, C1 joint, lateral mass of C1, the anterior arch of C1, and all the part of C2 and C1, C2 joint. So important also is that you can access to the prevertebral space, and we will see it very well in cadaver dissection and on the case. And the limit definitely is the contralateral vertebral artery, but you can a little bit extend this limit using the endoscope. So this is your surgical route when you do this kind of approach. You pass exactly in between the sternocleidomastoideum muscle and the internal jugular vein. And you have your accessory nerve, the 11th nerve, in the middle of your surgical field. So let's see a little bit of surgical anatomy, just some cartoons to summarize the importance of craniosacral junction muscles, and then we will see on the cadaver. So the superficial layer is definitely the sternocleidomastoideum and trapezium. The middle layer is done by big muscles like splenius capitis and semispinalis, and the digastric muscle that is the anterior limit of our approach, and longissimus and levator scapulae muscles. The deep layer, a really important layer, is done by the suboccipital triangle muscles, superior oblique, inferior oblique, and rectus capitis posterior major. Preserving this triangle, identifying this triangle is really important for the approach to identify and preserve the vertebral artery, as we will see. So let's focus on the suboccipital triangle. This is a lateral view, right side. So you have, you clearly see the deep layer of the muscle. So you have the superior oblique coming from the inferior nuchal line to the C1 tubercle, from the C1 tubercle to the C2 spine process. We have the inferior oblique, and then the rectus capitis posterior major from the inferior nuchal line to the spinal process of C2. You can see from the cadaveric dissection that the vertebral artery actually is really inside this triangle, surrounded by this venous plexus that you want, is protected by a periosteum layer that you want really to preserve to avoid any bleeding from this venous plexus during surgery. Let's see a little bit of the bony anatomy. So really important to identify for this kind of approach is the transverse process of C1 that you can palpate very well with your finger during the approach, and to identify also transfer foramen of the vertebral artery. The vertebral artery is the structure of this approach. As you can see here, you have this nice cartoon that show you the sulcus on the C1 posterior lamina of the vertebral artery, and from a lateral view, you will see that the vertebral artery comes vertical all the way up and then bend anteriorly and then again posteriorly at the level of C2 and C1. So this anatomy is particularly complex and may create some problem during surgery, mostly the segment around C2. And this is the view on top on the corner on the right side. You see the intradural part of the vertebral artery. These are radiological anatomy that you already seen from all this paper from Michael Bruneau and Bernard George. These are two anterior and a lateral view on a dry school. You see that when it's coming from C3, the vertebral artery goes laterally, and this segment is in between C1 and C2 is the most dangerous one because it's not covered by the bone. So if you come laterally, you see that you have really in front of you. So it's really a segment that you have to be most careful if it's surrounded by the tumor. When you have this posterior view, you see the same on the right side, the bending of the vertebral artery around C2. So you understand that if you come from laterally, you may injure it quite easily because it's not covered by the bone. It's not protected by the foramen intertransversarium. And this is the final view just to show you the vertebral artery on the sulcus on C1, and when it's going inside and becoming a B4 segment intradurally. Vertebral artery, we saw a lot already during this webinar about the vertebral artery. It may be tortuous in elderly patients, be careful with the head rotation. Extradural origin of the pica we already saw with Vittorio, and the anatomical relationship with the transverse foramen may change according to the head position. So more you rotate the head, more you expose this segment in between V1 and C1 and C2, and the more you increase this free segment that can be injured during surgery. You see the same while you rotate the head, the more you have you make disappearing the C1 anterior lamina. Another important structure that you want to preserve and to be aware of it during this approach is the extracranial exit of the facial nerve from the stylomastoid foramen. You can see here that the facial nerve is the right side, the lateral position. You see that the facial nerve is coming outside from all the muscle tendons that are attaching at the level of the tip of the mastoid, and for like 1 centimeter, 1.5 centimeters is the whole nerve, and then it divides into all the branches inside the parotid gland. So you want to be sure that when you do this kind of dissection and approach, you preserve your your anterior limit using the digastric muscle, the posterior belly, so you don't go further anterior and risk to injure the facial nerve. This is a zoom-in view, cartoon here from a paper from Antonio Bernardo that is really a nice explain the position of the facial nerve close to the tip of the mastoid. It's really important for this kind of approach to arrive prepared to surgery. So preoperative workup on radiological examination is really important. We already saw in the previous two presentations. So we got vessels, so the study of arteriography, angio CT scan to see the dominant side of the vertebral artery, eventually the presence of collateral circles, anomalies of vertebral arteries, the presence of complete bony canal around the vertebral artery on C1, eventually the tumor involvement and the situation of the contralateral vertebral artery. Another important thing to be aware is the eventually presence of a thrombosis of the internal jugular vein. It may happen because of the presence of the tumor. So you go there to identify the internal jugular vein, and you see that it's really filiform, it's really narrow. But the bone is really important to understand where is some lesion, some erosion of the bone, because the tumor like the chordoma, tumor that bite, that erode the bone. So you have a C1 lateral mass to analyze the joint between C1 and C2, eventually the involvement of the dens of C2 and the condyle. If you need to combine with the mastoidectomy, you want to know the mastoid pneumatization, eventually the ventral involvement of the clivus. So after that, you can be aware before going for tumor resection for the necessity of an eventual fixation. Intraoperative monitoring is really important in an approach like this to monitor both not only the nerves that are clearly on the surgical field, like the 11 nerve and 12 nerve, but also those that are a little bit more anterior or deep, like the 7 and 9, to be sure you don't injure them while you're preparing the approach. And eventually to understand if the tumor got an intradural extension extension and how much is the intradural extension to decide if it's much better to go for an anterolateral or posterolateral approach. So let's see the step-by-step surgical approach on a cadaver. So how we position the patient, how we do muscle dissection. The importance is we identify C1 and the transverse process of C1 and the accessory nerve, how to manage the vertebral artery and which corridor, surgical corridor you have according to where is the pathology. So the patient is positioned in a supine position with the head rotated more or less 30 to 45 degrees, depending both on the neck of the patient, on the size of the patient, trying to avoid elevation of the shoulder as possible. As you can see here on the picture on the left inferior corner, you see that you can use the rotation of your surgical table to increase the rotation without turning the head. For example, in a patient like this that already had the fixation previously. Patient position, the same, more you rotate the head, the more you increase the exposure of this segment of the vertebral artery between C1 and C2, so you expose it to major risks and you make the anterior arch of C1 disappearing. So the rotation is good because you need it, but you want to be aware that too much rotation may make your surgery much more difficult. Another important thing is to bend a little bit the head contralaterally to increase the space between the tip of the mastoid and C1 transverse process, because this will make your surgery, you will increase the space that you have for the approach. So skin incision goes from the superior nuchal line all the way down, crossing the sternocleidomastoideum at the level of the tip of the mastoid, and then following the ventral border of the sternocleidomastoideum. The inferior extension, it depends on the pathology, so you can go all the way down to C7 if necessary. So after the skin incision, you can see here on the cadaver, you want to identify the superficial layers. So after the platysma has gone, you want to see the sternocleidomastoideum muscle with superficial nerves and veins. After this, you want to know that your approach will be medial to the sternocleidomastoideum muscle, so you want to detach it and push it posteriorly. So this is a clearer view of the sternocleidomastoideum muscle, and this is where your approach will be. This is the mastoid tip. This is definitely the left side, as you can see. Superior nuchal line is here, so now we go in this direction and we detach the sternocleidomastoideum muscle and the splenius longissimus from the attachment. We want to remember this is a surgical view that, as I said, the dissection is between sternocleidomastoideum muscle and jugular vein. You follow the posterior edge of the digastric muscle as your anterior limit of the approach, and important is use your finger in this kind of approach, so you palpate the transverse process of C1 and the tip of the mastoid to understand where they are. After that, key important in this phase of the surgery is to identify the 11th nerve. It is inside the soft fat tissue, but you can use your neuromonitoring probe to identify it and feed it and keep it inside the fat pad. This is after retraction, posterior retraction of the superficial and middle layer muscles. As you can see, this tissue, fat pad tissue, with the 11 nerve inside has already been fed. You see that around before getting into the deep layer of the muscle, you got this connective tissue that obstructs your view at the beginning, so you want to dissect it, preserving possible the occipital artery before going and identifying the suboccipital muscles. This is a surgical view, so you can see the transverse process of C1 here clearly, and in the relationship with the tip of the mastoid. The 11th nerve is here, so inferior part of your surgical field, and we are posterior to the internal jugular vein. Here you see also the digastric muscle, that is the anterior limit of our approach. Again, on the cadaver, once dissected the connective tissue, we have the suboccipital triangle. So identify the three muscles: superior oblique, inferior oblique, erectus capitis, posterior major. Inside this triangle, we will find the C1 lamina, the vertebral artery inside the periosteum, and the venous plexus and the craniocervical dura of the craniocervical junction. You can see that the fat part is retracted inferiorly to protect the 11th nerve, and jugular internal jugular vein is anterior, and also the posterior belly digastric muscle is anterior to our approach. Here you see the transverse process of C1 clearly. So here now you want to detach all the muscle from here and deconnect and retract posteriorly the same. If you need the digastric muscle, posterior belly can be disconnected from the digastric groove on the mastoid and retracted inferiorly the same. So this is a zoom-in view of what we are almost doing. And then before doing that, it's really important to identify also another part of the kind of nerves which are inferior to the area that we were dissecting now. So we follow inferiorly the border of the ventral border of the sternocleidomastoidal muscle until we found the carotid bifurcation, the thyrolingual facial branch of the trunk of the internal jugular vein. And here you can see at the level more or less the carotid bifurcation, you have the hypoglossal nerve with the ansa hypoglossy running in this direction. And you have, if you retract posteriorly, internal jugular vein, you find all the branches of the vagus nerve. Now, so we are ready to detach the muscle from C1 transverse process and to identify the vertebral artery and dissect that area. So definitely you won't see an image like this in a patient because you don't want to see it. The vertebral artery needs to be kept inside the periosteum layer and inside the venous plexus so you don't damage it. This is the vertebral artery in the point where it comes from the C2 to the inside the C1 transverse process and goes inside the sulcus arteriosus of C1. And here, this picture, the vertebral artery is intentionally highlighted to show you the anatomy. Here you see also the rootless of C2 nerves. Once the C1 transverse process is opened, you can beginning to drill to a little bit with the diamond drill, and then you can bite with the Carison or punch plunger, and you open it. Once you open it, you have to free the vertebral artery from both the soft tissue that is all around and from the feeding arteries to the muscle that are in that area before eventually mobilize it. Now we can, at this point, once the vertebral artery is identified, we can divide actually the approach in two parts according to where is the pathology. So the 11th nerve is really in the middle of our surgical field. So if we need to address a pathology on the craniocervical junctions, we will go above the 11th nerve. If we need to go in the lower cervical spine and prevertebral space, we will go below the 11th nerve. You can see here the prevertebral on the right corner. You can see the prevertebral space more superficial to the longus colli. The same view, there are tumors that goes up and below the 11th nerve, so you can use both corridor, inferior and superior to the nerve. Transposition of vertebral artery is definitely a risky procedure, so you need to be aware how to do it. Keeping the periosteal sheath around the vertebral artery is really important to preserve it and to avoid important bleeding. There are really rare indications to do it only if the tumor is really at the level of C1, C2 joint and you want to remove a chordoma in that area. So we are above the 11th nerve, definitely here, that is protected by the fat pad. This was the images that we had before, vertebral artery with the C1 transverse process opened, and now after that you can, after a good dissection, you can transpose the vertebral artery and you see the C1, C2 joint that sometimes can be affected and involved by a chordoma, so you need to transpose the vertebral artery to remove the pathology in this area. So now let's see a small video that summarizes what we said so far. So this is a right side skin incision start from the neck. I will go a little bit more faster, otherwise we don't have time. So you dissect progressively the soft tissue until you have the ventral border of the sternocleidomastoideo muscle, and you start to see this connective tissue. Anteriorly, you have the posterior belly of the gastric muscle. You can see, you identify it, and so you have the anterior and posterior border of your approach. Sometimes it's more easy to find 11 nerve on a patient than during the cadaveric dissection, because in a patient you have definitely monitoring that helps you. But if you know where it is anatomically, you just look for it, dissecting carefully, and you identify that, as you can see here, the 11th nerve without damaging it. So it starts to come in your surgical field. Once you start to come in your surgical field, the 11th nerve, okay. Once you identify it, you start to disconnect from the superior nuchal line, the sternocleidomastoideo muscle, trying to preserve the periosteum, and you progressively detach it and transpose all the muscle posterior. You can see while you're cutting here, you want to preserve the occipital artery that is there. So in these images, you see and posterior belly of the gastric muscle, sternocleidomastoideo transposed posteriorly, and 11 nerve in the middle of your surgical field. So you start, as I told you before getting to deal with the vertebral artery, you want to identify with the other structure, and you look for the here the hypoglossal nerve, which is here more or less normally at the level of the carotid bifurcation. So once you identify it, you see the jugular vein can be very big in some patients, and also the theolingual fascial trunk. So you identify progressively the vagus branches and 12 nerves. So as I told you, with your finger, you palpate the transverse process of C1. And so you start the dissection in the area, you free and protect using this fat pad, the 11 nerve, you transpose it inferiorly, as I did in this dissection. So you start to see all the levator scapula, the longissimus, and the soft tissue that covers the suboccipital triangle. That one was the occipital artery. So this is sometimes is useful immediately to disconnect from the digastric groove, the posterior belly of the digastric muscle. When you do it, you want to be aware of the presence, as we told, of the facial nerve going outside the stylomastoid foramen, and the ninth nerve, which is there, and also the occipital artery that passes not so far from there. So once you got this, you increase your exposure, ventral exposure, anterior exposure. So occipital artery normally is preserved, in rare case of needed bypass. So here you have the rectoscapulis lateral muscle, RCL, that is the limit for the jugular foramen. So normally you preserve it if you don't need to go there. Now we start to disconnect, detach the muscle from the C1 transverse process and detach all the muscle posteriorly and inferiorly. So inferior oblique, superior oblique, rectoscapulis posterior major. And now we identify and expose the C1 transverse. This will be C1 posterior lamina, as you see, and the C1 transverse process. So then, as I told you, you start to drill over the foramen of the vertebral artery there with the diamond drill, definitely, to expose it and to identify. So here the foramen is covered here from the bone of the posterior arch of C1. So identify the vertebral artery, and before and after it goes inside the foramen, like it is partially open already here. So you complete the opening with the ronger like this, and then so you're ready to identify and to eventually transpose the vertebral artery, which is touched, as you can see from this periosteal sheet that you want to definitely preserve in patients. So some bleeding you have definitely, because there is some venous drainage from the muscle and from the muscle tip in that area. So once you are able to transpose posteriorly vertebral artery, as you can see here, you got nice images on C1, C2 joint. So we can continue the dissection below 11 nerve to identify better the vagus nerve and to dissect the muscle. So here, this is the view that you have. This is the vertebral, the area around C2 that you want to identify also if the tumor goes there. So vertebral artery is more or less already transposed. like this. So you have some attachment there that you want to disconnect. That's here. Now you have the C1, C2 joint in that point. So here you have. So this is the classic approach for the upper part of the craniocervical junction, the soft tissue dissection. We don't want to forget that Bernard George also described the oblique corpectomy, so an approach below the 11th nerve, which is good to avoid the necessity to put a cage there. So you can just with the oblique direction drill out the osteophyte and remove the compression from the cervical spinal cord. Let's see on the cadaver. So we go now below the C1, longus colli muscle. You see here, this is the prevertebral space posterior to the internal jugular vein. So you put the sector here, and with your finger you create this space like we do during the ACDF approaches, and you start to see the vertebral artery inside of the foramen and protected by the venous plexus. So on the cadaver you can nicely open all the processes and do whatever corpectomy or discectomy to identify all the structure there. You see all the rootlets of the cervical spine, cervical disc, and the vertebral bodies, and you can also look below contralaterally to the contralateral vertebral artery. This is a lateral view on the left side. You have also the C2 dents. Just a few pictures on the right side, patient on the right side to summarize everything. So vertebral artery completely exposed with the foramen opened. Digastric muscle is the limit of your dissection. 11 nerve is definitely on your way. As you can see here, internal jugular vein was transposed posterior in this cadaver to show the bifurcation of the common carotid artery in external and internal, and ansa hypoglossi here, and the ansa cervicalis there. So this is the 9th nerve, which is a little bit more deep in the direction of the styloid muscles. This is a more inferior view, inferior to the 12 nerve. As you can see all the nerve that goes through the larynx and thyroid, and all the bifurcation of the external carotid artery. Sometimes you need to combine these kind of approaches. Antero-lateral plus mastoidectomy, also described by Bernard George. Already Michael Bruneau talked about that. So you have this direction to the jugular foramen if you combine the anterolateral approach with the mastoidectomy. Sometimes not necessary to do the whole mastoidectomy, but doing the whole mastoidectomy gives you more surgical landmarks, and sometimes it's easier. So these are the 3 options for addressing a tumor in the jugular bulb. So we described a case a couple of years ago. Mr. Frolich. So this is step-by-step dissection. So once you finish, you see in the inferior part of the dissection, when you finish the approach, the anterolateral approach, so you can go to the mastoid here. The mastoidectomy is already almost done. You identify the facial nerve there. You start to see the jugular bulb. And you want to connect the intracranial and extracranial compartment. So you have to drill out all the mastoid tip and the jugular process to identify to connect the 2 places, and you have a lot of soft tissue muscle attachment there, so it's kind of not so easy to identify all the structure. You progressively identify the jugular process, which is the attachment here of the arterial muscle that has been removed, because otherwise if you don't remove rectoscapulis lateralis, you won't see the internal jugular vein completely going inside the head. So you just leave the jugular process and you bite it or drill it out, and you have here the nice view from the sigmoid sinus to the jugular bulb and all the way down to the internal jugular vein. So you have a nice extradural completely exposure of the jugular bulb. These are dissections done by our fellow Luigi Mauro in our lab. So This is an overview from the most up part of this approach that you can have, including the mastoidectomy, to the lower part on the cervical spine and prevertebral space. These are much more zoom in picture of the same thing. So just to conclude, the complications, you can have a vertebral artery injury because of tumor involvement. So important to study before if it is a dominant or non-dominant vertebral artery. You can have some problem with internal jugular vein, but it's really rare if you use the Buckey pants. You want to at the end stitch back very precisely the sternocleidomastoideo muscles to avoid any dehiscence, because it's a big muscle on skinny neck can be really evident dehiscence. You can incur an injury to the 11th nerve, which is not so common because the 11th nerve is a strong nerve, so you can have a palsy, and most of the time they recover. And if you don't are careful with your Bowie, you can injure the 7th nerve while you're dissecting the around the mastoid tip. Example case is just a particular case that we did with Sebastian, and we published it 4 years ago when I was in Paris. It's an antero-lateral approach for a recurrent chordoma cervical spine. So this was nice because we was operated in a different hospital. This was the case, and they did a partial removal with this graft and posterior fixation. So this section along the medial is the left side. This section along the medial edge of sternocleidomastoid muscle, which is transported posteriorly. This is the posterior belly of the digastric that is disconnected to increase the exposure. 11 nerve is identified using also the probe. Here is the 11th nerve inside the fat that is stimulated to be sure, and then is retracted posterior to identify. The occipital artery always is preserved. I go a little bit more fast and transpose it. You identify the internal jugular vein because it's your landmark. You want to be posterior to it. Internal jugular vein, occipital artery, C1 transverse profile. You palpate it. It's very close, more or less 1 or 2 centimeters below the mastoid tip. So you put a fixed retractor on the internal jugular vein. You start to feed the C1 transverse process from the muscle attachment. Once you've done it, you remove a little bit and you drill it to detach also the longus colli. So you are really here in the prevertebral space. So you start to see the chordoma here and the vertebral artery here. So you start the removal. The Doppler is very useful in case like this. This is the chordoma that is progressively debulked and removed until we arrive to the cage. So we had to drill out of the bone around that did the fixation actually, so and remove the cage to continue the tumor removal around that area. So in the end we arrive to the contralateral vertebral artery. This is the ipsilateral vertebral artery. This is transposed posteriorly, and then tumor removal continues until the dissection arrives to the opposite side. This is the contralateral vertebral artery. So at the end, endoscopy technique, the endoscope is necessary in case like this to increase your exposure on the contralateral side. As you can see, the rest of the chordoma is removed using the endoscopic assist technique and drilling around the bone, the pathological bone. So that was the dura. Exposed. So this is a tumor cavity fixed with the PMMA and the verification, finally the verification of the function of the 11th nerve. This is the final view. This is a take-home message. Use anatomical landmarks is really important. The lab dissection actually is really the same of the surgical dissection. You just have to coagulate before cutting. The same dissection that you do in the lab. You need really a perfect knowledge of the vertebral artery to locate it and be sure that you to reduce the risk of damaging it. It's an approach that is tailored to cranial-cervical junction or cervical spine pathology, normally extradural pathology. So thank you. Everybody is invited to our courses in our lab. We have vascular anastomosis courses soon in December with a few places is available. And we will have a 3D endoscopic course, 4th edition, in February with partnership with the ENS skull-base section with Daniel Roy. Thanks a lot. Okay. Anyone still alive? Amir? I'm by myself now.
No, I'm here.
Okay. Ciao, Vittorio.
Beautiful
So we are
talk.
waiting for Amir Dedashti. He's connecting. I will just give you 1 second to text him. Okay. Okay. Amir, can you turn on your video and your audio, please? Okay. Now I can see you, but we cannot hear you. Okay.
Can you hear me now?
Yes. How are you, Amir?
Okay, very good. I couldn't unmute before. The host wouldn't let me.
Okay. So
Okay, now
Amir
it's
Dedas
good.
is a great friend, and I'm very happy to have him here, and professor of neurosurgery, Northwell Hospital, New York. So Amir, please go ahead. Thank you.
Thank you very much, Paolo. Thank you very much. I thank you. I thank Sebastian Fröhlich, who involved me in this seminar or webinar. It's good that you talk so much about the anatomy, so I can only focus on the bypass and not going too much around the anatomy. I'm sure we are over time too, so everyone would appreciate if we have a shorter talk. This is what I'm going to talk about. Sebastian told me is really about the vertebral artery outside the brain. So I'm a bypass surgeon. All the bypasses I do usually are inside the brain, most of it, 95%. But of course, we have indications for bypass outside the cranial. And now I'm going to talk about that. I would like to acknowledge 2 people, Fady Charbel and William Caldwell, really by looking at what they have done with extracranial bypasses, specifically on the posterior circulation vertebral artery. I have learned a lot, and I have to, really tried to implicate that in my practice. And let's go over the indications. What are the indications really for the bypass on the vertebral artery? The number 1 is vertebrobasilar insufficiency. And this is a variety of area the vertebral artery can have narrowing. That could be from the ostium, starting at the origin from the subclavian, could be complete occlusion, could be very significant stenosis, and then could be higher up. The stenosis of the vertebral could be at V1, V2, and sometimes can extend up to V3, and we don't see anything else. What is very important, and I want you to pay attention, is the muscular collaterals that reconstitute the vertebral artery. This is a very important factor every time that you make a decision regarding a surgery on a vertebral artery that is occluded, because you definitely don't want to, or at least you want to minimize the amount of interference with those muscular collateral vessels. So VB insufficiency is the number 1 indication for us, at least as a neurosurgeon, as a stroke surgeon. What are the other indications that we use the vertebral artery for some sort of bypass? Is when we are dealing with aneurysm, specifically pica aneurysm, vertebral to pica junction aneurysm, subclavian steal syndrome. This is not something really that neurosurgeons deal with, but it's good to know about it. And also common carotid occlusion. If you have no other way to vascularize your carotid because the common carotid is occluded and the patient has carotid-related ischemia, vertebral artery could be as a very valuable donor in the neck and is actually better than, for instance, sometimes doing an STA-MCA bypass, as long as your internal is still open, but the problem is the common carotid that is occluded, which means that your internal is getting retrograde field by the external, but is not enough. Then you can just add a jump graft from vertebral to the carotid and basically renew a new carotid from the neck. So the surgical options, this is exclusive. This list is very inclusive. So we're starting from the V1 segment. When do we need, or a surgeon needs to use the V1 segment, which is the before entrance into the foramina for bypass? And that would be usually, generally, is for aortic aneurysm, is not in the indication of the, is not in the word of neurosurgeons, but you should know about it. Aortic aneurysm, where the aortic segment needs to be sacrificed or replaced, and we have to do something with the vertebral artery. So the V1 will be used to be mobilized and be implanted on common carotid. And this way, you can basically sacrifice or replace that segment of aortic without worrying about the vertebral artery. V2 is the more common area that the neurosurgeon gets involved, and that's the area that can be used for vertebral insufficiency. And that would be, could be anywhere, any segment in the vertebral artery V2 segment, which is from the transverse foramen C6 all the way to C1. But depending on how the angiogram looks like, depending on individual anatomy, I have usually used the V2 in the C1, C2, C3 segment. That's where we identify and be isolated for bypass. And then you can use radial artery or saphenous vein graft. So at V1, the vertebral artery has redundancy. You can actually bring it up and put it on the carotid. I'm going to show you an example. At V2, you can't do that because it's yes, it's redundant, but it's not that redundant. So you need to have a jump graft, radial artery graft or saphenous vein graft, and then you connect that to the V2, and then you can connect that to the common carotid or to the external carotid, depending on what type of bypass you want to do and to what vessel. Then we get to V3, which is again used for VB insufficiency as a good indication, and variety of option for V3. For V3, as a matter of fact, you can do the same indication for V2 as well. But for V3, because it's getting further away from the carotid artery, if you're doing a jump graft, one option could be, for instance, going from subclavian or the thyrocervical branch of the subclavian with a saphenous vein graft to V3, which is above the C1. The other option is to use occipital artery to V3 bypass to increase flow in the vertebral circulation. One caveat here is that we have to be very careful and look at the angiogram very carefully, because occipital artery sometimes is the collateral supply for posterior fossa when vertebral artery is deficient. So if you see a very robust collateral going from occipital artery to posterior circulation, it's not helpful to cut that occipital artery and anastomose on V3, because you cut some collaterals to create a new collateral. So that's something that has to be decided based on individual anatomy. And finally, V3 can be used as a donor for replacement of a pica with, for instance, radial artery graft. Saphenous vein graft can be used too, but radial artery is better because it's a better match. And finally, when we get to the V4 segment, anastomosis, the indication is rare. I would say only aneurysm in the V4 segment that you want to cut and re-anastomose is extremely unlikely, but that's one indication that you can use the V4 segment for bypass. So this is a good overview of all the bypasses that can happen on the vertebral artery. Some surgical consideration before I go through surgical cases quickly. The surgical exposure, Paolo showed very nicely the exposure of the vertebral artery, specifically the antero-lateral or so-called extreme lateral approach. One thing I have heard people saying sometimes that they cut the levator scapula to get to the region around the longus colli and the transverse process. I prefer not to cut the levator scapula. You know, the levator scapula is served by the dorsal scapular nerve, is helping the movement of the scapula. So it's better to work underneath it, and then you can cut the longus colli and expose the transverse process and get to the vertebral artery. When we do and consider doing a bypass on vertebral artery that is occluded and relies on collateral supply, very important to use the lowest segment. Usually these vascular collateral supplies are higher up, more cranial. So we don't want, and we have to avoid cutting the vertebral artery where there are those collaterals. So you have to be as caudal as possible. As mentioned earlier, keep occipital artery patent. This is very important because occipital artery is a secondary collateral supply to vertebral circulation, unless the angiogram completely confirms that it's not. And during this procedure, always we give heparinization a little bit more than when we do bypass inside the brain. When I do intracranial bypass, I give 2,000 units of heparin. When I'm doing outside the cranium, 5,000 units of heparin. And all these patients are on aspirin 81 or 325, depending on the pathology. One other very important thing about the occlusion time. Does it matter when we are dealing with VB insufficiency to occlude the vertebral artery? Does it matter? So if the subclavian is occluded and we are occluding the vertebral artery, remember, the vertebral artery has a retrograde flow. If the subclavian is occluded, the vertebral artery with the retrograde flow is serving almost as a blood supply to the arm. It's almost like putting a cuff on your arm and inflating it. So anesthesia, when they do that, usually after 45 minutes, 1 hour, they inflate for the blood flow to go back to the arm. So you have about 1 hour if the subclavian occluded. More than that, there would be a risk, not for the brain, but for the arm ischemia. However, if the V1 is occluded and subclavian is open, and then you have cranial muscular collaterals, as long as you're below those collaterals, the time is irrelevant because you have all the time you need to do the bypass because there are collateral cranial to you that contribute to vertebral artery. And when you have the vertebral artery origin and the V1 completely occluded in a dominant VA where is not relying on muscular collateral, that means that you still have a flow going through the vertebral artery, which is the dominant artery, but is significantly compromised. Typically, that would be like an in-stent stenosis, where endovascular team cannot open that stenosis for whatever reason it is, access or anything. Then the patient's brain depends on that anterograde flow, and you have to vascularize above that stent. So that means that your occlusion time is very crucial. It's direct ischemia to the brain. So that, obviously, the occlusion of the vertebral artery should be as short as possible, but usually these are simpler bypass to do. Yes, the vertebral artery is deep, is a deeper bypass, but for a bypass surgeon who does bypass inside the brain, let's say even MCA or in the Sylvian fissure, or like, let's say on 8383 or PCA, these bypasses are way easier than those bypasses. So it should not take more than 20 to 30 minutes to sew the vertebral artery in an end-to-side fashion. So these are the considerations that I would like you to keep in mind. Now, going to a few cases very quickly. I don't know how much time. I mean, I had said I want to talk only for 15 minutes, so I'm going to go quickly through all these regions to show you the different area of the bypass we can do. This is for V1. So for V1, you can see this is a big aneurysm at the aorta here. And when we are exposing the V1, this is done with a lateral incision over the subclavian region. And what we want to do here, we want to basically expose the carotid artery. This is being exposed. This is the common carotid that is exposed here. And that's pretty easy to expose the common carotid, especially on a thin person. And the other thing that you would like to make sure is the vagus nerve that is just behind it. You want to make sure that the vagus nerve is not damaged, so you can isolate that. And then in the subclavian triangle, you go medially to find the V1 segment. So remember here, what we want to do is we want to get the V1 and disconnect it from the subclavian and connect it to the common carotid. So that segment of the aorta can be treated without worry for vertebral artery and brain circulation. And this is a dominant vert. So you can see here, obviously dominant vert, we have a time issue here, so we have to be done as soon as possible. So you can see this is the vertebral artery that has been skeletonized in the V1 segment. A clamp is positioned distally. The proximal part is being clipped. And then it's a matter of cutting it, preparing the graft for this segment because the vessel is bugged in 8-0. I'm sorry, a 6-0 proline will be used. And this is a punch in the common carotid. And then it's a matter of sewing the vertebral artery to the common carotid as quick as possible, combination of running and interrupted. But these are very big vessels. So sewing on this is relatively easy. So residents and fellows can participate in doing this because these are relatively easy. And you can see this is the end product for the V1 segment. And basically now the carotid circulation participates to the circulation of the vertebral artery to the posterior circulation. Now we're going to go to another segment. This is a patient, a 35-year-old patient who presents with look at this young patient, unbelievable stroke in pica, posterior circulation here. And then we do an angiogram, and you can see the right vert is completely occluded in the V1 segment. I don't know if you see my arrow, but this significant muscular branch from the tyrocervical take over the... The arrow is visible?
Yeah.
Okay, perfect. The tyrocervical take over the vertebral artery by the muscular branches, and you can see this is almost at level of the V1. This is on the right side, but the patient also has mainly had a left-sided problem. And you see this is the left vert, the origin is occluded, but then there again, there is muscular branch comes up and contributes to this vert. So there is anterograde flow in both vertebral artery, but there is not enough flow because he is getting a major stroke and he has symptoms of VB insufficiency. And look at his PCOM. He has tiny PCOM on both sides. So none of the carotid injection shows the basilar circulation, which means that this is left, this is right. This means this patient is desperate for flow. So I'm waiting on this patient to get a NOVA MRA to confirm the lack of flow in the posterior circulation. And my plan would be to do what I'm going to show you in the next video, vertebral artery. And in this patient, because left is more symptomatic, but has already much stroke. So my plan is to do the bypass actually on the right side. So I'm going to do a common carotid, radial artery, vertebral artery bypass in this location, just below those muscular collaterals. I said, you never want to go there. So we're going to go and find the V2 segment between C2 and C3. So this is where it is. This is a left-sided approach. Here is exposure, as you know, I think Paolo alluded to a lot of these. We identify the common carotid, you identify the jugular vein, and in order to find the vertebral artery, you work under the jugular vein. And here, we go and open this fascia, the venous plexus that is around the vertebral artery. This is in the C2, C3 segment. You go here and you can identify the vertebral artery, and then there's redundancy. You can pull it back, so you get it out of the space, and then you have your graft here. That is the vertebral artery in the V2 segment is being clamped, and then we're going to open it and do an anastomosis with the graft. For vertebral artery, 8O is fine. 7O is fine too, but 8O nylon is perfect, depending on the size of it. But this vessel here, this is an 8O, is being used, the combination of running and interrupted. And then once this is done, this is the vertebral artery done, we unclamp, let the graft flow, take the clip off the vertebral artery, and then we let it bleed, and then put the clip back just above the connection. So this way the vertebral artery has its flow for now, and then we go and cut the graft around the jugular, come over the common carotid artery, cut the graft at an appropriate length, and this is the common carotid. The punch or aortic punch is being used, 5 or 4 number, depending on the size, and again a heel and toe of the anastomosis is sewn, and then we connect that with different sutures. So now we have a common carotid, graft, 2 vertebral artery, a good flow is notified, and that will take care of the VB insufficiency. And you can do that also to ECA. So it's not necessarily need to be common carotid, can very well be ECA. This is another situation for the same problem, but here, the other alternative for this is to use the subclavian. So in this situation, the patient needs, this is also in VB insufficiency, bilateral vert occlusion, and this is saphenous vein being harvested endoscopic, and the goal here is to identify the subclavian artery. So it's 2 incision. One is, and you can have vascular surgery help with that because they do that all the time. And then another incision is done behind the ear for kind of a far lateral exposure to identify the C1 in the C1 groove that actually Paolo was showing very nicely. In the suboccipital triangle, you find the vertebral artery, and that segment of the vertebral artery is very mobile. You use a tunnel to pass the saphenous vein graft, cut it at an appropriate size, and start clamping the vertebral artery, opening it with scissors, and basically go ahead and do a bypass between the vertebral artery and C1. This is there. And then the V2 anastomosis is done. unclamp the vert, put a clip on the graft so the vert still has whatever flow is still going through. So you don't want to keep it clamped for too long anyways. And then the graft is tunnelized under the skin. We come to the neck and connect that to the tyrocervical trunk of the subclavian. We don't need to put it right on the subclavian. You can use the tyrocervical. It's a perfect match with this saphenous vein. And that goes in. And then once you open it, you have a new vertebral artery. Incisions are closed. And this is a new vertebral artery reconstructed with this saphenous vein. Now, I talked about occipital artery, and I want to show you these pictures. You see how occipital artery and the vertebral artery are relatively close to each other. That's a suboccipital triangle with inferior oblique, superior oblique, and rectus capitis posterior major Paolo was talking about. And this is the occipital artery going up, and this is the vert. Look how close they are to each other. So in an ideal situation, you would say, just bring this down and connect to vert, and that will give you, look how occipital artery and vert could be close to each other in this picture. So that's the only downside is that, as I said, occipital artery 50% of the time participate in the collateral blood supply to the posterior fossa, specifically when there is vertebral artery insufficiency. So that has to be ruled out before this be considered as an option. But then we can take the occipital artery, bring it down, and put it on the vert, and that could be a very nice and very, actually, I would say, slick procedure. We can do it with a small incision, where we can follow the occipital artery with a small curvilinear incision, follow the occipital artery from external, go as high as we can, separate it and bring it back. That's one way of doing it. One of my friend and colleague in Idaho, Andre, has done that, and that's a very nice way of doing it. The only problem is that you might have some limitation in terms of length. So the other option is to really harvest the occipital artery the way we do for aneurysm. And I'm going to show you how you should harvest the occipital artery. The best way to, this is a patient with an ICA aneurysm. I'm not going to focus on that. I'm going to just focus on showing you how we harvest the occipital artery. So harvest the occipital artery the same way that we do the superficial temporal artery, from inside out, in the sense that you start from the most proximal segment. This is where it starts just behind the occipital groove, and the occipital artery is identified, and then we just dissect it out and follow it. So this is much more natural because it's from proximal flow to distal flow, and you use Colorado tip around to keep a good fascia around it, and that will give you a very nice occipital artery here. You can see that's the occipital artery you have. You can have the length that you need, and look at this, the flow that you can get, and this is very long and it's perfect. And the vertebral artery here is going to be right there, right where my the hand is. You see this hand? This is where the vertebral artery. In this patient, I wanted to use this occipital artery for ICA, so I really need the length, and I'm going to bring it intracranial. But if it was for extracranial, the vert is right there, so I can just put it there if needed. So that's how I would suggest the occipital artery to be harvested. So in this patient here, this is a patient that need an occipital artery V3 bypass for the VB insufficiency. This is the occipital artery. That's what I showed you, the way it was harvested. And then we'll bring it back. You have the V3 segment exposed, clip on either side, and then it's just a matter of sewing the vertebral artery and occipital artery together. Vertebral artery, sometimes, especially the V3 segment, can have sclerosis and atheroma in the wall. So sometimes you need to do an atherectomy, almost like an endarterectomy. I don't know if the last case I'm going to show has that. Or as long as you can keep the flap and the atheroma inside the suture, then it's fine, because you just need the flow. If there is a little bit of atheroma, it's not that much of an issue. What you don't want to happen is that the area of your anastomosis create a flap with the atheroma of the vertebral artery, and that will occlude your bypass. So that's you don't want to happen, because then will be very difficult to restore the flow once the thrombus is inside it or it propagates distally into cranial components. So when this bypass is done here, you have this, and then either side is connected, and it's just a simple extracranial occipital artery VA bypass, and you add additional flow to the brain. So this is also one example. ICG confirms the good flow. And finally, what else we can do with the vertebral artery in the head? This is a patient with a subarachnoid hemorrhage, significant subarachnoid hemorrhage, mainly in the posterior fossa. You can see she already has a very significant vasospasm, has this distal segment pica aneurysm that cannot be sacrificed. It's a major pica. It's on the second segment, lateral medullary segment of pica. This patient doesn't have a good occipital artery. She does not have contralateral pica for pica-pica bypass. Is not a segment where side cutting and reanastomosing is easy. Is a pretty significant length, and you can see on the 3D pictures. In this space, you don't have much of redundancy to reconnect the pica together because there are lots of perforators there. So if you do that, you might have a limitation in terms of mobilization. It's very different than if you do an end-to-end at the tonsillomedullary segment of the pica or even telovelotonsillar. Anteromedullary, lateromedullary, you do not have redundancy. So the only option for revascularization, and this is not a clippable aneurysm, you have to sacrifice this segment. The only option here is to use the vertebral artery as a donor, radial artery, and pica as recipient. So here you can see the same thing. This is a right-sided approach. Vertebral artery is exposed in the V3 segment. One thing I want to emphasize, you see all this coagulation around, this is for venous plexus. The venous plexus around the vertebral artery is very robust. Sometimes the bleeding from it almost looks like an artery, but it's not an artery, because if you have ever encountered the bleeding from the vertebral artery, you know how it is. And I hope you never encounter, but you know how it is. And those venous bleeding that could at times be pretty serious, it's still very easily manageable. As long as you identify the vertebral artery, you can coagulate and shrink those tissue, and you get to this situation when you have the vertebral artery. And then now we have to isolate the vertebral artery. I have used a radial artery graft here, and this radial artery and the pica in the tonsillomedullary segment, and Fady is over the aneurysm. And then we go ahead and cut this suture with a 9-0, the radial artery to pica in an end-to-side fashion. And then coming back now to the extracranial and V3 segment, you see here, there is a little bit of atheroma, I believe. You can see here the atheroma. So I'm not doing an endarterectomy. What I'm trying to do is to make sure that the atheroma and the flap all is taken together with the suture. And the radial artery has been sewn to V3, like the previous video that I showed, a combination of running. I think here run the whole thing. And then it's a matter of occlusion time. Again, as I said, we want to usually keep it not longer than 30 minutes and should not be longer than that, quite frankly. Even with residents or fellow participating in putting some of the sutures, you back bleed from the distal verts to get the blood out from the graft, make sure that there is no clot anywhere. Back bleed, put the clip back, suture the last tie, and then this is the final product from VA to pica. So extracranial VA to pica, that's the last indication that I showed you. And then we go here and just distal, we clip the aneurysm distally, put a clip distal to the aneurysm, is one way of flow diversion, and that will basically immediately kill the aneurysm. And this clip comes off the pica, and you can see this is the graft from extracranial component. Obviously, during closure, we have to make sure that there is no tension on this thing. And this is the ICG showing the graft is open, and this is the final product with the graft is open, and you can see the aneurysm that was there is not visible anymore because there was a distal clip. The distal clip flow diversion cured the aneurysm, and the graft is taking care of the pica circulation. As last one that I mentioned to you, I don't have any experience with it on the V4. It's extremely rare that we do a bypass, and that would be reanastomosis if you have an aneurysm on a V4 segment. But quite frankly, many of those aneurysms are amenable to endovascular treatment because if there is a need for sacrifice at that segment, usually the other side can take over. But again, those indications are rare for V4 bypass intracranially. That's it for me, and thank you very much for your attention. If there is any questions, I don't know if you want to have a discussion briefly.
Okay, thank you, Amir. Very nice cases. Congratulations. Okay, so Sebastian, we will not be able to, Sebastian Fritsch will not be able to connect. Just send me a message. He's in trouble it's not in trouble, but it's very busy in the OR, so it's not going to do the presentation. So I think we are done for today, and we will see next month for the craniocervical junction anatomy.